welcome to the Deep Dive. Today we're tackling something really complex, not your standard case of primary Sjogren's syndrome or PSS.
No, not at all.
We're looking at its, well, catastrophic potential through a specific case study. It's one where the medical team basically had to become detectives.
Absolutely. Navigating this maze of overlapping autoimmune symptoms, it was incredibly challenging. And all of it, ultimately, was masking something far more serious.
A malignancy, right.
Exactly. That's the real tension here. You know, for most people, Sjogren's means, well, chronic dry eyes, dry mouth. Annoying, but manageable.
But this case?
This case, involving a 55-year-old patient, let's call her Shushi, it shows how the immune system didn't just target her tear and salivary glands. It went systemic, a full-scale attack, really.
Affecting multiple organ systems and eventually leading to cancer.
Precisely. So our mission today is to kind of pull out those key diagnostic nuggets. What separates that chronic dryness from, a systemic disaster like this?
Okay, let's unpack this then, starting at the beginning. Who was Shushi?
Right. So she was a 55-year-old homemaker. And this is important. She wasn't entirely new to autoimmune issues.
She already had a history.
Yes, she was already on thyroxine for known autoimmune thyroiditis. So you could say she was already potentially predisposed, maybe higher risk for another autoimmune condition.
Okay, so predisposed. What were her initial complaints that pointed towards PSS specifically?
Well, her initial complaints were pretty much the classic baseline for PSS. She'd been dealing with severe dryness, the sickest symptoms, for about 3 years.
3 years is a long time.
It is. And severe enough that she needed artificial tears frequently, just constant use.
And it wasn't just discomfort, was it? It sounds like it affected her daily life significantly.
Oh, absolutely. The dryness had moved way beyond simple irritation. It was a serious functional issue. For 2 years, she'd had trouble swallowing dry foods, things like biscuits or chapatis.
So she needed water constantly.
Constantly. And because of that lack of protective saliva, she was suffering from recurrent dental caries. Lots of cavities.
That paints a pretty clear picture of xerostomia, the dry mouth.
Yes, end-stage salivary gland dysfunction, basically. And adding to that, for about a year, she'd also had intermittent swelling in her parotid glands, coming and going.
Okay, so those are the symptoms she reported. How did the doctors confirm this wasn't just, bad allergies or some other form of irritation? How did they nail down this crisis level of dryness?
They used the standard diagnostic toolkit, but the results were stark. I mean, really definitive.
What did they find physically?
Physically, her eyes showed severely dry conjunctiva, a decreased tear film, that little meniscus of tears at the bottom of the eye was barely there, and orally, dry mucosa, a fissured tongue, poor saliva pooling. It looked dry.
And the objective tests?
That's where the numbers really tell the story. Her Schirmer's test measuring tear production showed less than 5 millimeters of wetting in 5 minutes.
Wow, that's very low.
That's not just dry eyes. That's a critical lack of function. And similarly, her salivary flow test was markedly reduced. It confirmed the oral side of the crisis.
Given how clear those functional tests were the Schirmer's, the salivary flow, why push for the labial salivary gland biopsy? What extra piece of the puzzle did that provide?
That's a really great question, because the functional tests, they tell you what's happening. The glands aren't working, but they don't necessarily tell you why.
Oh, okay.
The biopsy gives you the structural evidence, the underlying cause. And in her case, it showed focal lymphocytic sialadenitis, crucially, with a focus score greater than 1.
And that score is the key.
That score is the definitive proof. It's the microscopic evidence that immune cells, lymphocytes, are actively infiltrating and destroying those salivary gland tissues. It locks in the PSS diagnosis and rules out other things that can cause dryness.
So the PSS diagnosis is confirmed, but then things take a turn. After 3 years of these, localized dryness symptoms, the immune attack seems to spread.
Exactly. It goes systemic. And this is where it starts mimicking other serious conditions.
What were the first signs of that systemic spread?
The first major clue was musculoskeletal. For about a year, she'd been having joint pain, symmetrical in the small joints of her hands, and importantly, associated with morning stiffness that lasted over 30 minutes.
That sounds textbook rheumatoid arthritis.
It absolutely does. That description screams inflammatory arthritis, making RA a top suspect.
And then came the really alarming symptoms, right? The constitutional ones.
Yes, and these only emerged in the 3 months just before she came for this consultation. These are the symptoms that really shift the perspective from a chronic, manageable issue to something potentially life-threatening.
What were they specifically?
Unexplained weight loss, 5 kilograms in just 3 months. pervasive fatigue, low-grade fevers, and persistent night sweats.
If the dryness was the sort of chronic background noise.
Then these constitutional symptoms are like a blaring siren. Something is seriously wrong systemically, and her lab work backed this up.
What did the blood tests show?
They showed clear signs of chronic inflammation. Anemia, the type you see with chronic disease. Her ESR was elevated, CRP mildly up. And signs of liver involvement too, mild transaminitis. Her liver enzymes were a bit off.
Okay, so now it's a real diagnostic challenge. You've got symptoms pointing to Sjogren, symptoms pointing strongly to RA, these worrying constitutional symptoms that could be lupus or even something else. How do they start sorting this out? What did her specific autoimmune markers, the scorecard, show?
The scorecard was absolutely vital here. It provided both confirmation for PSS and contrast for the mimics. She was strongly positive for anti-SSA, Rho, and anti-XSP low.
Which are classic Sjogren's antibodies.
Exactly. Strong support for the PSS diagnosis. But she was also positive for rheumatoid factor, RF.
Which supports the RA picture. Muddies the water again.
It definitely does. But the key often lies in what's not there, in the negative results. That's how they started to untangle it.
How so? How did they differentiate PSS from RA and maybe SLE?
It comes down to specificity. Modern immunology gives us highly specific markers. So yes, she had the joint pain and the positive RF, very suggestive of RA. But crucially, her anti-CCP antibody test was negative.
An anti-CCP is highly specific for RA.
Very specific. A negative result there makes RA much less likely as the primary driver, despite the symptoms and the RF. It doesn't completely rule it out, but it points away from it being the main issue.
Okay, so RA is less likely. What about lupus, given the fever, weight loss?
Right. SLE was definitely considered because of those systemic features. But again, the specific marker anti-dsDNA was negative. Another key differential pushed down the list.
That's fascinating. It really highlights how crucial those specific antibody tests are. If this case had presented, say, 20 years ago before anti-CCP was widely available.
Oh, absolutely. It could easily have been misdiagnosed, likely as seropositive RA, potentially leading to the wrong treatment path for years. It's like trying to find, the one truly bad apple in a barrel, where lots of them look a bit bruised. They seem similar, but getting it wrong has big consequences.
So modern diagnostics helped pinpoint PSS as the main culprit behind the joint pain and likely the systemic inflammation. But there was another potential mimic, right? Sarcoidosis.
Yes, that was considered too, especially because she had the parotid gland swelling and her HRCT scan of the chest showed mild interstitial lung disease, mild ILD. Both can be features of sarcoidosis.
The biopsy ruled that out.
Again, the labial salivary gland biopsy was definitive. The pattern was classic Sjogren's, not the granulomas you'd expect in sarcoidosis. So they could confidently attribute the arthritis, the dryness, the mild lung involvement, all to a very active systemic PSS.
Okay, so we have a diagnosis. Severe systemic PSS hitting the joints, eyes, mouth, even the lungs.
Yeah.
But those really worrying constitutional symptoms, the weight loss, the night sweats, they still feel a bit ominous, not fully explained just by those findings.
Exactly. And that brings us to the most serious turn in this case. The findings related to her lymphoreticular system.
What did they find on physical examination?
On exam, they noted mild swelling of the lymph nodes in her neck, cervical lymphadenopathy, and also palpable nodes in her armpits, the axillary region. They felt reactive, enlarged.
And internally.
She also had mild hepatosplenomegaly. Her liver and spleen were slightly enlarged. Taken together, this signals that the body's immune surveillance and drainage system, the lymph system, is under significant stress. It could be just from overwhelming autoimmune activity or
something worse.
Or something worse, like a malignancy developing within that system.
Did the imaging give any clues there? You mentioned the parotid swelling earlier.
Yes, the ultrasound of her parotid glands was quite suspicious in this context. It showed what's described as a heterogeneous structure, basically uneven texture, with multiple dark spots, hypoechoic areas.
What do they usually mean?
Well, that appearance can be seen in long-standing Sjogren's itself. But when you see that combined with new systemic symptoms like weight loss, night sweats, and palpable lymph nodes elsewhere, it should immediately raise a huge red flag for lymphoid transformation.
The potential development of lymphoma.
Precisely. The conversion to cancer.
Was there anything about the nature of the parotid swelling itself, just by feeling it or looking at it, that should have rung alarm bells for non-Hodgkin's lymphoma even before the ultrasound? Or was it really the combination of findings?
Often, the clinical tip-off in the gland itself is a change in its character. If swelling that used to come and go becomes persistent, maybe hardens, feels non-tender, or becomes very asymmetrical, that dramatically increases suspicion.
But in this case,
In this case, while the ultrasound was suggestive, it seems the constitutional symptoms, the weight loss, the night sweats were really the most powerful non-localized signals that this patient might have crossed a dangerous line from just high-risk PSS into an active crisis, potentially lymphoma.
right. So let's get to the finding that really clarified the prognosis, the lymph node biopsy. What did it show?
This was the definitive step. The biopsy of one of the enlarged nodes showed reactive hyperplasia, meaning the node was enlarged due to immune activity, which you'd expect. But, crucially, amidst that reaction, there were atypical lymphoid cells, abnormal-looking immune cells.
And that means?
That finding is highly suspicious for non-Hodgkin's lymphoma NHL. It's not definitive proof on its own necessarily, needing further confirmation, but it points strongly in that direction.
It's a known complication of Sjogren's, isn't it? The lymphoma risk.
Yes, although thankfully it's not the most common outcome. Only about 5 to 10% of PSS patients develop NHL. However, among all autoimmune diseases, Sjogren's carries one of the highest risks for lymphoma development. And this patient, sadly, was showing the full clinical picture, suggesting that transformation was happening.
So the final picture is just devastating. Primary Sjogren's syndrome, complicated by severe dry eyes and mouth, inflammatory arthritis, mild lung disease, and now highly suspected non-Hodgkin's lymphoma.
Right. The PSS isn't just a background condition anymore. It's the context, the fertile ground from which this malignancy likely arose. It demonstrates how that initial, seemingly localized attack on the glands could act as a launchpad for systemic chaos.
Immune cells going rogue, compromising the lungs, and critically transforming within the lymphoreticular system itself.
That's the key lesson here.
Okay, shifting to management. This poor patient needs complex, aggressive treatment on two fronts simultaneously. How do you even approach that? Managing the chronic PSS symptoms while also tackling a likely life-threatening cancer.
It requires a very careful, multi-layered approach. You can't ignore either aspect. First, you have to address the quality of life issues from the Sjogren's itself.
The symptomatic care.
Exactly. So, aggressive use of artificial tears like methylcellulose drops, saliva substitutes, practical things like sugar-free gum to stimulate any remaining saliva flow, and meticulous dental care, including topical fluoride, to manage those caries.
Okay, that handles the dryness. What about the underlying autoimmune drivers, the arthritis, the fatigue?
For those systemic PSS manifestations, the standard approach is hydroxychloroquine. It's the baseline treatment often used for the joint pain and fatigue in PSS. They might also try cholinergic agonists, drugs like pilocarpine or suvamline, to try and chemically stimulate any residual function in the salivary and tear glands.
So trying to manage the autoimmune fire even while dealing with a potential cancer.
Yes, it's important to try and stabilize the underlying autoimmune disease as much as possible. But you have to be realistic. Those treatments aren't going to touch the more severe complications like the ILD or the suspected lymphoma.
Right, so what's needed for those critical issues?
For the mild interstitial lung disease, stronger immunosuppressants are usually required to prevent progression and lung scarring. Something like mycophenolate mofetil or azathioprine would likely be considered.
But the lymphoma takes precedence.
Absolutely. The suspicion of NHL changes everything. That requires immediate, urgent referral to hematology and oncology specialists.
For what exactly? Confirmation treatment.
Both. They need to perform further tests, maybe repeat biopsies or specialized studies, to definitively confirm the NHL diagnosis and determine its specific type and stage. And then, based on that, develop a treatment plan likely involving chemotherapy or other targeted therapies, which is completely separate from the PSS management. The lymphoma becomes the immediate priority.
This case is it's such a powerful illustration of the sheer breadth of autoimmune disease, how something presenting as simple dryness can spiral into this multi-system collapse.
It really is. Ocular, mucocutaneous, musculoskeletal, respiratory, immunological, lymphoreticular, constitutional. It hit almost every domain.
And it really hammers home the danger of overlooking those constitutional symptoms, doesn't it?
It absolutely does. Remember, the weight loss and night sweats were the last things to appear in her timeline. Yet, they were the harbingers of the most dangerous complication, the transition from chronic illness to malignancy. Dismissing those as just part of the chronic fatigue could have been disastrous.
So, that leads us to the provocative thought for you, the listener, to consider. We've seen how vigilance was absolutely critical here. It was the difference between potentially catching this earlier versus dealing with advanced disease. So the question is, what kind of rapid, maybe cost-effective screening tools should become standard practice the moment those red flag symptoms, unexplained weight loss, persistent night sweats appear in a patient with long-standing high-risk PSS.
Yeah. How do we shift from just managing the chronic dryness and fatigue to actively, systematically screening for malignancy in those high-risk individuals who start showing subtle systemic changes? Because that vigilance, that proactive search, might be the highest form of care we can offer in such a complex disease.
A really vital and, frankly, sobering deep dive into the potential reality for some patients with Sjogren syndrome. Thank you for joining us and engaging with these complex sources today.